Good afternoon, everybody here in auditorium and those of us watching us live on YouTube and other social media. Today, we are talking about technology and health and aging safely. And as I walked in the auditorium and four of our speakers were here, I said we're so appropriately dressed as if we are here for the funeral, all of us in black. And it was so completely not coordinated and unintentional. So this is the classic information. I just want to make sure that everybody knows that CDC Grand Rounds are not an event anymore. It's an enterprise. And if you look at all these websites and emails, you can tweet, you can post us, you can like us, unlike us, do all these kinds of things. One new segment, if you haven't seen it, is called Beyond the Data, where we have a very brief interview with one of the speakers after the session, either John Iskender or I. We're basically just send the key messages. So today we are talking about aging, and this is really an extremely interesting topic because sooner or later, some of us sooner and some of you later, we're all gonna get there. And it doesn't always have to be fun, but it can be fun. And I wanted to share with you just a little bit of a personal aspect from what it means to age and still be very active. This is an email that my mom sent to me at CDC 5 years ago in 2008. At that time, she was 79 years old. And of course, I assume that there are very few people, even though I see one person here who can read Croatian, most people won't. And so I'm translating. It said, my first email, no period, just I am trying, Mom. 6 months later, here's a long email to me and my daughter because we're born on the same day. And it reads, dear girls, no periods and all of this, but there is text. Happy birthday, love you and are proud of you, your old parents at their 163 years combined. My father was 83 at that point and my mother was 80. So as the famous philosopher Yogi Berra said, the future ain't what it used to be. And the future is changing for all of us. And what used to be the primary way of communication has definitely changed, and everybody is texting and calling. And if you watch one of the shows on TV, I watched House of Cards last night. It's a show about an iPhone. Basically, what happens all the time is somebody's on the iPhone and you're looking at the iPhone screen. And so when I say everybody is texting, I really mean everybody. And this is what older people actually have their own acronyms. So this is not talk to you later, as some of you young people might think. It's talk to you louder. And this is the one that my kids loved the most when I was your age. So let me just say a few words about our speakers today. I was really having a hard time finding lookalikes for these people because these people are, dressed in black, that's one thing. But the other one is they really are smart and beautiful. I mean, look at them. This is one of the best looking panels we've had. And you know that looking good and stylish is very important for the Grand Rounds. So here are our speakers, Linda Anderson from CDC, Carrie Bruce, Brian Jones, and Leanne West from Georgia Tech. I have looked at the most intelligent people in Hollywood who have IQs above 130. And the lookalikes, people who we have here are Sharon Stone, Ashley Judd, Quentin Tarantino, and Mira Sorvino. What can I say? So to bring us back to the topic, I want to thank our expert, Andre Harris, who has done the science clips this week for us. And as you can see, the topics of the articles are related to what we are talking about today. And one thing that I do have to comment is that these are people from Georgia Tech. This is the first time we're really doing this intense collaboration. One before that was done, John did one with the American Academy of Pediatrics. But working with Georgia Tech people has been really fun and exciting, but they use a lot of product names and technology, and I was warned that I have to make a statement. We're not advertising any of it or endorsing, we're just using it to explain to you and give a bunch of examples. And with that, we're going to have a few words from our director. Thank you.
Every day, about 10,000 Americans celebrate their 65th birthday. And as the baby boomers age and life expectancy continues to increase, this will continue through 2030. By then, 1 in 5 people in the U.S. will be over the age of 65, and 9 million will be 85 or older, more than double the current number. Not so long ago, people who reached age 65 didn't expect to live much longer. Today, many expect to be able to run a marathon. Today's older Americans want to stay active, interact with family and friends, and be involved in their communities. And they want to age in place. That means living in their own home, safely, independently, and comfortably. Today, we'll take a look at some technological innovations that could allow older adults to do just that. Meeting the new demographic realities demands new ways of thinking, creative partnerships, and innovation. Those of you in the technology field are critical partners, helping older adults live safely and independently, both inside and outside of their homes. Your contributions are both valuable and timely. Thank you.
Good afternoon. I'm Linda Anderson. I'm the Program Director of the Healthy Aging here at CDC. And I'd like to begin the session today by describing the population characteristics of older adults, laying out really what we think about as a demographic imperative regarding the importance of our aging society. And the number of people aged 65 or older today is greater than the total number of people throughout the history of the world who ever reached age 65. As a result, the aging of the population can be thought of as a new frontier, one that we'll explore today and examine how technology can play an important role in helping promote independence and safety of older adults. And there's really no agreement about the exact age that signifies an older adult, and the definition can shift according to society as well as culture. And for the purposes of our presentation today, I focus on adults age 65 and older, and this age is consistent for age eligibility of Medicare coverage, as well as our older adults topic area in Healthy People 2020. So as this slide shows, between 1900 and 2050, we see a large growth in this population. So at the beginning of the 20th century, there were about 3 million adults aged 65 or older, and that was about 4% of the population. In 2011, we saw the leading age of the baby boomers begin to turn 65. And then there were about 35 million people aged 65 or older, about 13% of the population. And by 2030, the proportion of those aged 65 or older will more than double to about 72 million people, and they'll make up about 20% of the population. However, it's really important to note the growth in the oldest old age group, and those who are 85 years or older. This is the group that's at greatest risk for experiencing frailty as well as needing long-term care services. In about 2010, there were about 4.2 million persons aged 85 or older, and that's projected as to increase to about 9 million people in 2030. So you may be sitting there thinking about this is only happening in a few select states. So I guess right now you might be thinking, well, this is something unique to Florida, or even perhaps thinking about Arizona. But that's not quite true. So I want to look at the age distribution across the country over time. So in 2000, only 4 states, one of which was Florida, but the others included Iowa, Pennsylvania, and West Virginia. And they had 15% of their population aged 65 or older. And it's important to note at this time, not a single state had over 20%. So let's forward to 2015, which is just 2 years from now, and this is what you see. It's projected that 32 states will have 15% of their population aged 65 or older. And even more striking, in Florida, for the very first time, 20% or more of their population will be made up of persons who are aged 65 or older. And if we forward to 2025, we see that 27 states, 20% or more of their population will be aged 65 or older, and only 2 of those states, and 2 states lag behind, California and Alaska. So in addition to thinking about the growth in the proportion of number of older adults, there are other important shifts to consider in this population. The population of older adults will become more diverse over time, and between 2010 and 2050, 2 major trends are projected. First, there will be an overall decrease in the percentage of non-Hispanic whites from 80% to about 58% in 2015. And at the same time, we see increases in other racial and ethnic groups. So educational attainment, as you know, has major effects throughout the life course, which in turn plays an important role in the health and well-being of older adults. Higher levels of education are usually associated with higher incomes, higher standards of living, and above average health. And this chart shows that increases in educational attainment among older adults between 1965 and 2010. The light blue line shows the percentage of older high schools with a high school degree or more. So in 1965, about 24% had a high school degree or more, whereas in 2010, this was about 80%. And the percentage of older adults with at least a bachelor's degree, shown in the dark blue line, rose from 5% in 1965 to 23% in 2010. So people living in the U.S. are living longer than ever before. Our life expectancy, which is a summary measure, represents the average number of years of life remaining to a person at a given age if our death rates were to remain constant. So a child born in 2009 has an average life expectancy of about 76 years of male and about 81 years of female. At age 65, men are expected to live on average about 18 years more years, and women about 20 more years. And for those who may retire around this age, those adults may spend a quarter or more of their life in those retirement years. And when we look at age 85, men can expect to live on average about 6 more years, and women about 7 more years. The living arrangements of older adults are linked to both health status and whether or not they have access to family and friends who can provide assistance as needed. And of particular interest is the percentage of older adults who live alone. 19% of men, which is shown in light blue, and 37% of women in dark blue lived alone in 2010. We also can see that living alone differs by race and Hispanic origin. And in 2009, only 4% of people age 65 or older were within a long-term care facility. And this is a particularly important point, that the vast majority of older adults live in the community, and therefore many of the technologies will need to focus on community-dwelling adults. So changes in functioning also have important implications for work and retirement strategies, health and long-term care needs, as well as social well-being. And here are 5 sets of physical activities that have been used to assess functioning. About 19% of men and 30% of women reported that they were unable to perform at least one of these 5 activities. But important to note is that for people aged 85 and older, 40% of men and 53% of women were unable to perform at least one of these 5 activities. So the technological innovations can both assist people to regain functioning as well as adapting to changes in functioning. Another important area is living with multiple chronic conditions, as they can negatively affect quality of life, contributing to declines in functioning, as well as increased risk of being institutionalized. In addition, medication regimens are much more complex and difficult to manage. And so multiple chronic conditions are defined as having 2 or more chronic conditions lasting longer than 6 months. And based on recent Centers for Medicare and Medicare data, 68% of adults aged 65 or older, more than 21 million adults, had multiple chronic conditions. And for those aged 85 or older, 83% had multiple chronic conditions. So finally, I wanted to present a model of thinking about healthy aging, and I hope that by introducing these components of the model helps set the stage for our colleagues' presentations from Georgia Tech. So the first component relates to optimizing physical, cognitive, and mental health. The second component relates to facilitating social engagement. And the final component relates to promoting health and along with preventing injuries as well as managing chronic conditions. So as you hear about the technological innovations of our Georgia Tech colleagues, please keep in mind these various components of the model. And although this model focuses on an individual, it can further be enhanced by overlaying a social ecological framework, looking at how families, how neighbors, and how systems can promote optimal aging and help assure that older adults live safely and independently for as long as possible. And now I'll introduce our next speaker, Carrie Bruce.
Good afternoon. I'm Carrie Bruce, and I'm a research scientist and speech-language pathologist from the Center for Assistive Technology and Environmental Access at Georgia Tech, and I'll be talking about supportive design strategies that facilitate function, independence, and safety. When an individual has a chronic condition, an impairment, or an age-related functional decline, his or her independence and safety are impacted. The design of spaces and products creates barriers or facilitators to performance depending on that person's level of function. Generally speaking, most typical everyday designs assume that the majority of users will have an average level of function. This means that people who have less than average function may be deliberately excluded from or will likely have difficulty using these designs. Furthermore, it's often presumed that function for one ability equals function for all abilities. However, we know that in reality, a person's level of function varies across all of their abilities and fluctuates over their lifespan. Consequently, typical everyday design often doesn't meet the needs of older adults. And typically, design contributes to activity performance when it's typical design. These problems can lead to decreased community engagement and participation, as found in research that was conducted by colleagues at my center. They showed that design of kitchen and bathroom features were most limiting to older adults' performance, and that these performance problems were significantly correlated to less mobility within their communities. Supportive design is a strategy that can minimize or eliminate these barriers and performance problems. Several researchers have investigated the impact of supportive design on performance, including the use of home modifications to reduce difficulties. For example, work done at Washington University showed that older adults who received modifications reported improved daily activity performance that was sustained 2 years post-intervention. Supportive design strategies include not only specialized design, but also universal design. Specialized design compensates for specific disabilities and functional limitations. It includes assistive technology and accessible design. Conversely, universal design promotes use by people with various abilities and a range of functional levels. I want to briefly define the 2 types of specialized design here. Assistive technology is any item, piece of equipment, or product system, whether acquired commercially, modified, or customized, that's used to increase, maintain, or improve functional capabilities of individuals with disabilities. In contrast, accessible designs are products, spaces, or site-built features, often promulgated through codes and standards that compensate for functional limitations by minimizing environmental demands on individuals with disabilities. The primary difference between these two is that assistive technology is typically something that people take with them from environment to environment, while accessible design is something that's considered a semi-permanent or a permanent change to the physical environment. Even though assistive technology and accessible design are different types of specialized design, they result in similar positive outcomes, including increased independence, greater confidence in performing activities, improved effectiveness of caregivers, and more frequent community travel. They can also result in reduced functional decline and disability, decreased likelihood of institutionalization, and lowered risk of falls. Along with the benefits to specialized design come the barriers to actual use and long-term adoption. First, there's often a yuck factor to specialized design. Quite often, it's a Band-Aid approach to design that no longer works or never worked to begin with, and therefore it looks added on. Specialized design also tends to be disability-centric. There's a me mentality, which means that it only supports specific types and levels of ability, so it becomes a barrier to other people. A long-standing complaint of specialized design is that it looks special. It's stigmatizing, it brings attention to a user, and it reminds people that they have a disability. And finally, specialized design can be big and clunky, it's hard to move, it's hard to store, and it doesn't quite fit in with the rest of the person's environment. Universal design, as the other type of supportive design strategy, is broader than specialized design in that it meets the needs of a larger number of people with and without disabilities. It's defined as the design of all products and environments to be usable by all people to the greatest extent possible without the need for adaptation or specialized design. There are 7 principles, including equitable use, flexibility in use, simple and intuitive use, perceptible information, tolerance for error, low physical effort, and size and space for approach and use. These principles promote everyday design that supports all types and levels of abilities. There are several benefits to universal design when you compare it to typical and specialized design. Universal design results in spaces and products that have personal scale and nature, yet still meet the needs of multiple users with varying functional levels. It's also able to support a wide range of functional levels across a person's lifespan, including function that's dependent on assistive technology. So if a person has to use a wheelchair in their bathroom, a universally designed space and bathroom fixtures would be able to accommodate this need. In the larger scope of design practice, universal design can also lead us away from the need for specialized design by setting a new bar for usability of spaces and products. And finally, an interesting and clinically relevant benefit is that universal design is compatible with the ICF framework of activity and participation. To conclude, I want to highlight a few important points. Designs that are intended to be used by people who are aging must assume that people experience functional changes and that a person may have more than one chronic condition that results in functional decline or disability. Also, while function, independence, and safety outcomes should be the main considerations, the use and adoption of spaces and technologies are also influenced by other factors such as how something looks or fits in with that person's life. Finally, universal design is generally the best practice for designing spaces and products. However, there are situations where combinations of different types of design is the best solution for that person. Our next speaker is Brian Jones.
Hello, I'm Brian Jones, Director of the Aware Home Research Initiative at Georgia Tech, where I work with a number of faculty and students from several disciplines across campus as well as from other universities to research and develop new technology innovations intended to improve the lives of individuals living at home. Technology to support aging in place has been a strong focus. Our efforts have included increasing independence through social engagement, maintaining wellness, and increasing autonomy in daily living, as well as improving health outcomes by helping individuals better self-manage chronic disease while considering the needs of their care network, such as family and professionals. One of our resources in this research is the Aware Home at Georgia Tech. This facility provides an authentic home environment in which to innovate the next home technology, perform human subject studies of our research in a controlled environment, and to test installation of solutions before deploying into actual people's homes. Today I'll provide a brief overview of these 6 areas of technologies currently on the market, which are designed to support older adults aging in place more safely and independently. Along the way, I'll describe some of the research that Georgia Tech is conducting in these areas. Many families first turn to the Personal Emergency Response System, or PERS, to provide increased safety and peace of mind for their loved one. You've probably seen or heard of these devices from the commercials of "I've fallen and I can't get up." Pressing the button on the wrist or the pendant initiates a call to a monitoring company who will then get help in getting assistance for the individual. Some systems might provide GPS and a cellular connection to allow the individual to use the button away from the home. Other systems are capable of automatically detecting falls by using an accelerometer sensor in the device that can detect patterns that are similar to a fall, and then automatically summoning help. There are also systems on the market that can be installed in the home to provide an ambient or passive monitoring. Using motion sensors or door sensors and similar sensors placed in strategic locations around the home, these systems allow caregivers to better understand whether a person is going about their typical day or if something might be wrong. For example, if motion is only triggered in the bedroom well past the typical wake time for the individual, they may not be feeling well that day. Georgia Tech is also considering how monitoring systems can be used to trigger safety alerts. As one solution, our students have created a project called Remind Me, a picture frame with images of a space heater, an iron, and a stove to be hung in a common area in the home. When the iron is turned on in a different room, the LEDs on the frame around the iron image light up and stay lit. A motion sensor in the room where the iron is able to determine if any motion has been detected in the last minute or not. And if not, it will trigger the LEDs around this iron to start flashing and then play some audio, music or similar, to indicate that there's a possible hazard to the individual in the home. Medication adherence or non-adherence is an expensive health problem. Most commonly, older adults simply forget to take their medications or have trouble managing multiple medications. A no-tech pill box, for example, might be a simple first option, and then reminders such as a watch or smart apps on cell phones might provide that the trigger, the reminder to take the medication. For a single pill reminder, a smart cap or bottle might be useful. The portable Clever Cap, shown in this picture, blinks and displays audio when it's time to take the medication. When the user dispenses the pills, it communicates the time and the number of pills dispensed onto a caregiving portal. Multiple pill dispensers alert the individual when it's time to take the medications and are capable of dispensing multiple pills multiple times each day, with some of these systems able to handle up to 4 weeks of medication. Social communication is particularly important for older adults living alone. Several technologies are available attempting to meet the needs of older adults, including phones designed considering simplicity and reduced dexterity, hearing, and vision, often experienced by older adults, or systems that allow easy digital transfer of handwritten letters, or devices that provide easier virtual video visitation with loved ones. At Georgia Tech, we have students considering what devices might be useful to provide easier communication options for older adults. One example is called Onacom. It provides one interface for texting, email, and instant messaging. An early version, shown on the left here, uses physical tabs representing contacts. Pull a tab or tabs, and then pressing the right button on the device will allow the user to write a note out and then send it to the preferred communication mode for the recipients. For example, I might wish to receive the message through email, while my kids might prefer a text message. Personal wellness is important to maintain health and independence. Today, there are many devices available to help track exercise, sleep, and weight. Connected pedometers like the Fitbit are able to track steps, number of steps a day, climbing of stairs, level of activity, as well as sleep restlessness. Connected weight scales can send your weight to a portal and allow you to see your trends. Some devices can also measure heart rate and skin temperature. In this image of a tool designed at Georgia Tech, we designed it to visualize the trends of potentially related health data. The plot shows exercise in blue increasing as the weight in green decreases. Georgia Tech has also conducted a study where several measures were captured automatically from the various sources listed on this slide and analyzed it using a new app called Salud Mobile that was developed at Georgia Tech. The app also provides simple self-report options for logging food, mood, and pain each day. The app can plot a person's steps or show pain levels on a calendar. It can also provide observations, such as on days when you are more restless during sleep, you have more pain. These types of observations can be important for understanding one's patterns and may help in the individual in getting the care that they need. Wellness information may also have application in managing chronic diseases through monitoring of diet, exercise, weight, and taking medications. Telehealth systems allow more frequent measurement of vital signs at home or activity in the home and can help in identifying important trends that may not otherwise be detected. For example, increased nighttime roaming or frequent bathroom visits may indicate a health problem that the person does not realize that they actually have. From a health perspective, Georgia Tech is considering how water lines and power lines in the home can be used to determine the typical day, as well as detect changes in behavior that are not typical. The ElectroSense system is capable of detecting noise on the power line and determining which device is turned on or off. So if we can detect whether a refrigerator door was opened, a TV turned on, or a light switched on or off, can we recognize the patterns representative of a typical day for that individual? Similarly, the HydroSense system measures pressure changes on a water line. It can be trained to recognize patterns of water use, such as showers or toilet use, the dishwashers running, drinking water, or washing of hands. These sensors have been validated for accurately determining these events on the lines, but we have not yet deployed the systems into people's actual homes for tracking over longer periods of time. For the purposes of testing such systems, we have created Homelab. Homelab is a network of 425 participants and growing up to 550 who are willing to evaluate technologies such as our research or that from industry in their homes and in their lives. We maintain information about these individuals to help us quickly identify who would be a good candidate for a specific study. Researchers will conduct studies that range from a 60-minute interview to a 6-month in-home study, depending on the type of product being tested. I hope this talk has provided insight into the systems currently available to assist older adults, as well as some of our research at Georgia Tech designed to extend today's solutions and provide greater independence and improved outcomes in the future. Our next speaker is Leanne West. Thank you.
Good afternoon. My name is Leanne West from Georgia Tech, and I will be talking to you today about individual-centered technology. I'm the director of the Landmark Research Center, where we focus on mobile health applications and the integration with sensor technologies. Okay, so individual-centered health. Why now? Technology is no longer a limiting factor for really anything. Mobile technology is everywhere. Smartphones and wireless access are ubiquitous. And one fun fact I often hear at the mobile health conferences I go to is that globally, more people have access to a cell phone than they do a toothbrush. So contemplate that. People will expect to have access to information all the time, in real time, anywhere they are. And so why should health information be any different? Here are two recent headlines from an online news source that I like, Moby Health News. And they are Apple hires health sensor talent likely for iWatch. There's a lot of major players in this field, like Nike with Fitbit that you heard Brian talk about, and there are others entering the market too, just like Samsung and Qualcomm recently announced smartwatches as well. The other headline is that the mobile health sensor market will reach $5.6 billion by 2017. Now, when you compare that to $407 million in 2012, that shows tremendous growth in this market. And so you can start imagining what our future is going to look like. All right, so while these technologies can help people of different ages, such as universal design that you heard from Carrie, and things like the Nike Fitbit or the Apple iWatch that you heard about just a minute ago, you can imagine that these technologies are really more important for some people who are trying to live alone as they age, want to age in place. So the first project that I'm going to talk about that we've worked on is called the Intelligent Bathroom. And it's an internally sponsored project that was really meant as a proof of concept. So why the bathroom? The bathroom is a room that someone will go to every day in their activities of daily living, or they should go every day. And the activities in the bathroom really make it ideal to monitor what's going on with somebody's health. So you can imagine the sensors in the home being, you can imagine these sensors being used in the home or being used in an extended care facility. And we envision all of the sensors that I'm going to talk about working together and with the person's healthcare record to really understand the health of that individual as they age. All right, so the first thing I'm going to talk about is the intelligent mirror. And you've probably all been in a hotel room that has had a television behind the mirror. And you can imagine, though, that this television behind the mirror can give you more than just the news in the morning as you're getting ready. So we developed an interactive prototype with speech control and visual tests. It has face recognition for two reasons. One is to know when somebody is looking at the mirror, so it knows when to take an image of the person. And the other is to know who the person is, because you want to make sure that if you're looking at the chronic condition of someone, that you're actually evaluating the correct individual. And so for any Facebook users out there, face recognition software on Facebook can actually identify your friends in your photos. And so you can imagine how remarkable this could be. And the technology is really already there for us. There are two cameras that we use. We use a visible camera and an infrared camera. The infrared camera gives a temperature map of the person, so you can look and see if the person has a fever or if there's maybe a hot spot on the skin indicating some sort of skin condition that you might want to check out. In addition to that, we used a visible camera, and this was used to not only identify the person, but also to look at monitoring the activities of daily living through image and video analysis. And so some of the other things we think about are, if you're looking at the individual and you're taking pictures every day, can you tell the person is getting more gaunt? Can you look at the range of motion that that person has? That they used to brush their hair like this, and now it's kind of more like this with their arm down. What about their skin color? Are they maybe more jaundiced than they were? So thinking about multispectral imaging. And also body position. Are they not quite standing the same way that they did before? And so looking at trends over time. All right, we've also considered a floor, and we looked at a variety of sensors that could be used in the floor. We decided on the We Fit feet because they are really cheap and readily available, and they were also easy to program for, and you can see one of the feet in the middle sensor, in the middle image. And we wanted to use the floor for multiple purposes: to detect weight, to detect balance, to detect falls, to detect gait as you walk across the room, and then also to have the floor act as a trigger. So has someone entered the bathroom? Which person has entered the bathroom? We can tell perhaps by the weight, or the weight in conjunction with the face recognition from the mirror. And then we also want to use the floor to see, has the person stepped off of the floor to step into the shower, and for how long? All of these things can be measured when you have some intelligence in the floor system. All right, lastly for the bathroom, we looked at an intelligent toilet, which is everybody's favorite subject. But we think that this is a great place for health information. And you can imagine doing a real-time urinalysis every time you use the restroom. And so at Georgia Tech, we developed a chem biosensor, shown in the upper right picture, for the military. And it's been tested for the military, but what we want to do is transition this technology into everyday use. And so it can detect up to 40 agents at a time. They can include bacteria, viruses, blood, proteins, drugs, a variety of things in the urine with really high sensitivity. It's also an optical sensor, so it can detect things such as color, pH, turbidity, other things that are important when you're trying to analyze someone's urine. The sensor may or may not involve the use of a collection cup, depending on how we want to try to track volume of urine released during the day or during the night. And then we also, if I want to leave the toilet now, I know y'all are sad, we also thought about other possible sensors in the home. So we found some things on the market, like the faucet you see, that can do things. It has face recognition. It can tell you what the temperature of the water is by the color of the water. It can control the flow for you, depending on if you're a child or an adult. And we also thought about other things like a smart toothbrush, for example, a toothbrush that could collect saliva and maybe do some analysis there. So we're really trying to, again, know about the complete picture of the person. All right, now to step away from the bathroom for a minute, we have another project called I Care For You. It's a mobile health application, and this app was developed also on internal funding. And we have had discussions with a couple of companies to license it because I personally want to use this with my mom. Many products that we see on the market have a clinician portal and a patient portal, but there's another really important person in this realm of keeping somebody healthy, and that's the caregiver, whether it's a family member or a paid professional. And we developed this in conjunction with paid professionals. So what the app does is it will notify a caregiver when a reading is taken, and therefore you also know when a reading is not taken from at-home health sensors like a blood pressure cuff, like a blood glucose monitor, weight, temperature, etc. The screen notifies you that the reading's been taken. It tells you what the latest reading is. It tells you if it's out of range of out of the range specified by the clinician. And you can also view a history of the readings to look at trends. And we gave just a really simple user interface, because this is what was desired, to where you can push a button and you can call the individual if you see a troubling reading. You can call the doctor if you see a troubling reading. And let's just say I live here and my mom lives in Nashville and I want to contact her, but she is not responding to my calls. We also built in a contact list of neighbors and families and friends who live nearby that could go check on that individual. Another product we're working on is with a small company called Sensiotech. They are building a wireless vital signs monitor, and there are several groups around Georgia Tech, not just mine, helping Sensiotech with their software and hardware implementation. The sensor technology uses an antenna, and it collects heart rate, respiratory rate, and movement of the individual through a panel that sits under their mattress or in a chair. And we have functional prototypes that have been approved by the FDA. And we have recently outfitted 12 beds at the Atlanta Medical Center to collect data to optimize the algorithms that is taking all of this information and trying to make sense of it for the doctor. The product is envisioned to be used with both adults and infants. And you can really imagine that on the infants as well, how much better it would be to see a child without all the wires attached. And for me, really, this is one of the more exciting products because I see how close it is to being on the market and how useful it can really be. So I've given you some examples of some of the individual-centered health research that we have going on at Georgia Tech, and I hope that they help you imagine what our future can look like in healthy and safe aging. And I want to reintroduce Linda Anderson for some closing remarks.
So you can see from the presentations of our Georgia Tech colleagues that the technology landscape is rapidly evolving. And I hope everyone saw the many linkages between really sort of the engineering, public health, and medicine, as well as the aging services network and family caregivers. So I want to use in sort of my closing remarks the social ecological model that I mentioned earlier to underscore the importance of sort of moving further beyond individual-oriented technologies to applying these technologies to relationships, community, and the societal level. So at the individual level, we heard about a number of technologies. One example was medication reminders that varied from the pill box reminders to those complex automated dispensing systems that could service over a long period of time. At the relationship level, we heard about technologies that enabled families or professionals to monitor health as well as mobility. And these included things like the patient safety monitoring systems, such as the app that provided vital sign readings along with an alert system. And then at the community level, we heard about technologies aimed at the physical environment, such as smart homes or the intelligent bathroom. And those systems help to create environments that are tailored to older adults' needs and can communicate with external resources. These are important when we think about emergency response situations. And then at the societal level, we heard about the importance of universal design that helps ensure that inclusion of all people with various abilities and a range of functional levels, as well as social communications that help ensure social engagement. So public health can work to ensure we reach populations in need, but there's several factors that we need to consider. One is the accessibility of the technologies. Older adults are increasingly using technology in their daily lives, but it's still really limited. And in 2008, only 38% of older adults used the internet or email. And in 2012, this had increased to only 53%. Another issue is affordability, and although technology is becoming clearly more affordable, it's still beyond the resources of many families. So many of the assistive technologies require direct out-of-pocket costs to individuals as well as their families. And adaptability and adoptability also need to be considered. And as these technologies must evolve both to meet the increasing needs of the diverse population, and in order to promote adoption, we need to also address issues around stigma around technologies, as well as resistance to the use of certain technologies. So addressing issues of confidentiality and privacy is also critical. This is a particular concern when we think of people who may have cognitive impairments and decision-making issues. Also important are issues related to scalability as well as sustainability. And our Georgia Tech colleagues have described a really robust body of research and pilot projects that can be built upon, and public health can really work to advocate for training, for testing, as well as translating those technologies for public health practice. And finally, the growing population of older adults is often overlooked and often an untapped resource. They can be actively engaged to ensure that they benefit from the technology and that we continue to benefit from the contributions of older adults. So thank you, and now we'll be happy to take questions. We'll take questions first from the floor. Please introduce your name, give your name, and provide a brief question.
Thanks so much. Ted Johnson, Emory Center for Health and Aging. What's the cost point that we have to cross that makes these technologies that are available ubiquitous in our homes? What is that dollar figure that makes people get these in their homes?
So from talking with a number of the companies out in the market that have been looking at more monthly service charges related to these instead of charging for the specific technology, they're trying to hit in the $30 to $50 range to give you some idea. And usually they're thinking in terms of a 3-year use of, it depends on the technology, but a 3-year use is what they're targeting.
Other questions?
Yes, Dee Miriam. I'm with the Healthy Community Design Initiative and the Center for Environmental Health. And I think this is all great at a small scale, but what about the community design, the pedestrian infrastructure, the transit accommodations, things like that? Where is that? How does that fit into this model?
I'm going to try to answer that. I think there are a lot of efforts on the front of community accessibility within the universal design arena. There are a few different efforts at Georgia Tech within our urban design department that are looking at aging in place and aging within community. So as we move forward, we're trying to evolve out of accessibility into this universal design philosophy that people come from all ages and all abilities and are going to need to use that same space. So we're trying not to partake in the same types of designs that we have over the last 20 years and since the inception of ADA, which has focused on people having specialized designs and different entrances and different places to be based on the fact that they use assistive technologies and need that accessible space.
And I also think, this is Linda, that one of the interaction, again, as you said, these really complement each other. And so we're looking in the Healthy Aging Research Network at sort of how the environmental design of environmental audits and other kinds of tools can be integrated and interact with some of these technologies to assist people in moving and finding their way through the environment. So I think some of them, while many of the technologies here have focused on the home, many of those can be taken out to really assist people in engaging in healthcare and engaging in other environments.
Hey, Laura Cyphers with CDC NCEZID. I'm a student, so the acronyms are new for me. How many of these changes do you see being paid for by Medicare? Sorry.
There we go. So right now it depends on the state, as I understand it. So in the state of Georgia, I think the personal emergency response system is about the level at which they'll cover with Medicare. There are other states, however, where they're starting to look at these solutions that can be deployed into the home for monitoring individuals from a health perspective. The telemedicine systems and especially the coaching aspect where, as we're starting to see this turnaround in our healthcare system from pay-for-service to more outcomes-based, those kinds of systems are going to become more, I don't know that Medicare will pay for it, but certainly the healthcare field will be paying for it in some way to ensure that patients are staying in their home and they're not getting taxed for or penalized for somebody coming back into the hospital.
Hi. My name is Kason Schmidt. I'm with the Public Health Law Group. The first question, I actually have two questions. The first question I have, I hear a lot of you talking about collecting a lot of data from all these sensors throughout the house. What sort of efforts are in place to aggregate all of that data into user-friendly models, for instance, maybe in the application of healthcare, maybe integration into electronic health records, or even big data approaches?
So there are a lot of different projects going on around campus to address exactly that question. There's a lot of big data efforts. I know that my group is specifically looking at what you can do with all of the data to aggregate it and make algorithms that are useful and turn it into something that's meaningful and actionable by the clinician so that they can, if you're taking heart rate data 24 hours a day on somebody 7 days a week, clearly all of that data cannot go into your medical record, right? So you have to figure out what pieces of that are important, what you want to keep, what you want to pass forward. But one of the challenges why that question is not really answered yet is because we haven't really been taking that data yet. All these sensors are really new to the market, and so we're just starting to try to address those types of things.
Thank you. My second question is kind of associated with the collection of all this data. There are a lot of people out there that tend to be a little suspicious of technology. And are there efforts in place or planned to address a lot of those suspicions so a lot of these really tremendously beneficial technologies can be embraced instead of approached with prohibitive caution?
So yes, we have been considering the security of these technologies and certainly the privacy aspects. One of the, I'll say, related fields, technologies that's out there is our TV in our home, and those equally can give up a lot of information about our, how we're living our lives at home, or even conversations in our home. So these are bigger discussions than we're covering here today, but we do have people on campus who are starting to look at the health side of this, and specifically how health information should be protected. As information is flowing, as we're talking about from a healthcare provider to healthcare provider for better delivery of healthcare, we're going to have those protections in place.
Thank you. I'm going to take a call from social media.
Yes, from our online audiences, several very similar questions. Specifically, how do you convince seniors who are not receptive to technology to use and implement? Are you planning for that in your presentations?
A lot of the research that I do is related to trying to understand the perception that older adults have of technology and working that into models of adoption, but also into models of how clinicians and service providers work and interact with older adults. So I think we have a lot to learn because technology is changing, and there are issues about suspicion, and there are issues about, does this work for me, and what does it really collect, and what does it really share? And so that research is super, super important at this point, and we're working very hard at trying to understand the perceptions of older adults, especially as we move into this potential area of robots. There's a lot of reticence on the part of older adults to accept robots as part of daily living and health technologies, et cetera.
So we'll take one last question from the audience.
Thank you. I'm Peggy Highsmith with our Office of Safety, Security, and Management. It's recently been reorganized, but formerly OSHI and ESHCO. But my question, in your studies, do you see an alignment with those states that already have a growing population, above the 65, with embracing some of the technologies and approaches either in universal design or home monitoring? Do you see, for example, Florida, Pennsylvania, and some of those others making preparations already?
So as I had mentioned a little earlier, the states that are embracing these technologies are those who are starting to put their foot forward on the policy side and say, okay, our Medicare will cover these kinds of technologies. The ones that I'm thinking of, Pennsylvania is one, Minnesota is another, and California are three that stand out. I haven't been keeping track of Florida, but these, just from following some of the reports back from the Center for Aging Services Technologies out of Leading Age, which is in DC. They have done a number of these studies to see what technologies, how technologies are being adopted, what technologies are gonna really make a play out there, and then looking at the policy side to ensure that the right policies are in place for these technologies to take off.
And can I just get clarification? Do you mean Medicaid rather than Medicare, since it's a state-based system? I just want to clarify which system, because Medicare often is sort of that federal insurance system. So I think that many of the states would be employing long-term care services out of their Medicaid programs, and then we'd be looking at some of the newer innovations in terms of care coordination out of CMMI and others out of Medicare. So I think those are things to be looking forward. Thank you.
Thank you very much. One of the signs that the session was successful is when you have to end it and there are still questions. So I really appreciate the audience engagement and interest. And thank you very much. We'll see you next month, same time, same place. And can I ask you for another round of applause for our speakers?